Hi, I'm Megan Lott, and I'm the Deputy Director for Healthy Eating Research, a national program of the Robert Wood Johnson Foundation based at Duke University. I'm happy to be part of this panel today, and I'm excited to talk to you about how the foods we eat every day are really determined by the settings in which we spend most of our time, the communities in which we live, and the policies and systems that shape what those built environments look like. And of course, how this is all an important part of the food as medicine model. But first, I want to tell you a bit more about the Healthy Eating Research Program in order to give you some insight into the perspective I'm bringing to the conversation. We are a research program, and our primary goal is to support research on food and nutrition that will advance the Robert Wood Johnson Foundation's efforts to ensure that all children and their families have the opportunity and resources to experience the best physical, social, and emotional health possible, promote health equity, and build a culture of health. We do this by focusing on policy systems and environmental strategies that have strong potential to promote healthy eating among children, especially among lower income and racial and ethnic minority population groups that are at highest risk for poor health and well-being and nutrition-related health disparities. All of our work really falls into three main buckets, our program goals, which are building the research base to identify what works, building a vibrant, diverse community and field of researchers, and translating research findings into information that can be used by decision makers to, quite simply put, ensure that healthy choices are easy and available in all communities. When looking at the top 10 risk factors for global death, 7 of the 10 can be linked back to diet. The most recent national data available on US rates of obesity and diet illustrate that Americans still are not consuming enough fruits, vegetables, dairy, and whole grains. But we are getting too many added sugars, saturated fats, and sodium, mostly in the form of sweetened beverages, desserts, and snacks, leading to high rates of obesity and the chronic diseases you see listed here on this slide. It's also important to note that Americans do not suffer from obesity and obesity-related chronic diseases at the same rates. We continue to face significant public health problems with large geographic, income, race, and ethnicity-based disparities when it comes to these chronic diseases. So individual actions and choices are really important targets for behavior change, but to assume they are the only thing determining our daily dietary choices would be a bit naive. It's also imperative that people live in an environment that supports good decisions, and that's where policy systems and environments come in. They are significant determinants of children's dietary intake, weight, and health. And over the past 20 years, there's been a really growing emphasis on their importance. PSE strategies, as we often refer to them, go beyond education and information programming to really embed changes in a community. They're designed to be more sustainable and reach a larger number of people than programming alone. PSE changes aim to create communities where healthy choices are easy, safe, practical, and affordable for all. So let's talk about this in the context of the socio-ecological model. This is the SEM from a really food and nutrition point of view by looking at the examples on the screen. The individual factors, including knowledge, skills, lifestyle, biology, and demographics, are often what you see when this is tailored for any discipline. The social environments and networks, similarly, family, friends, and peers are very similar. In the physical environment, this is the home, the work sites, the childcare, schools, et cetera, where we're spending a lot of our time. And then the macro environment, such as industry, food productions and systems, food marketing, food retail, healthcare systems, and other policies and legislative opportunities really have a big impact on the choices available to us in our communities. Originally, when healthy eating research first started back in 2005, most of our work focused just on these two outermost layers, the physical environment and the macro level environment. But over the past 5 years, we've really expanded to now focus our work across all of the levels, recognizing the importance of layering approaches to really have a long-lasting impact on behavior change. So here's an example I think really illustrates some of this work. The primary focus of this study was to assess how changes in the retail or the food environment in close proximity to children's homes affect changes in children's BMI. Children with increased exposure to convenience stores, seen on the left, were more likely to experience an increase in BMI over time. So if you look at the y-axis over here, you see there are 3 time points for children living within 1 mile of a convenience store at 12 months, 18 months, 24 months, and then similarly for children living within a half mile at those time points and within a quarter mile of those time points. And the children living at a quarter mile or less from a convenience store over time had a much higher BMI than those living a mile or more away. In contrast, those with greater exposure to small grocery stores selling a selection of healthy items were less likely to experience an increase in BMI, and that's represented by the chart on the right. So similarly, you can see that people living 1 mile or more from a small grocery store had a decreased BMI, but the closer you get down to half mile and then quarter mile, that moves back towards the center here. And this really, going back to what I was speaking earlier about individual behavior change being really important, we can do a lot of education to individuals about what is healthy to eat. But if they're living in a community with no access to these healthy foods that the dietary guidelines for Americans recommend should be part of a healthy dietary pattern, or that we know is really important for preventing obesity and chronic disease, it's a false choice. They can't make the healthy choice if the healthy choice isn't even available in the first place. And that's where policy systems, environmental changes come in. So here are some examples of PSC change approaches that healthy eating research has really worked on over the years. And I wanted to highlight some of these to illustrate a few more areas. So for example, one policy change we saw as part of the Affordable Care Act back in 2010 was to have calorie and nutrient labeling on menus in restaurants and food retail venues around the country. Now, the research has not shown that having that information available has led to dramatic changes in what people are ordering. However, those same studies have shown that people really value having that nutrition information available and being able to make informed choices. And while they might still choose the menu item they walked in intending to choose for that particular meal, it does help them think about the context of that choice in the rest of the day, and maybe they make healthier choices later to balance it out. Similarly, we have done a lot of work to get nutrition standards for foods and beverages available in childcare facilities and schools, and to look at the implementation of those. And there's a lot of research looking at both standards through, school meal programs or the child and adult care feeding program that shows that they are serving healthier foods than non-participating sites, and kids' nutritional quality received through those meals is far superior to foods brought from home. When looking at systems change here, we're really talking about changes that might not be passed through a policy, but are looking across a lot of a bigger system for impact. So for example, the healthcare system, there are many different leverage points within that system that don't rely on policy change, but can be implemented, like screening for food insecurity and community clinics and pediatric practices now being a recommended practice by the American Academy of Pediatrics and several other groups, has really led to increased referrals for families who are having a hard time finding enough food to programs like the Supplemental Nutrition Assistance Program or WIC, the Supplemental Program for Women, Infants, and Children, so that they have additional resources to incorporate healthy foods into their diets. And looking at the environment, again, we talked about the healthy food retail environment. That's a perfect example. There are not a lot of policies impacting what is available in healthy food retail. However, we have seen new minimum stocking standards and staple food ordinances passing at the local level, which really set a baseline essentially for providing a minimum number of healthy foods in these smaller stores, such that we see more healthy options available in these communities. Another example here I just want to highlight really quickly is around SSB taxes. So definitely that is one that falls in this changing or charging higher prices for less healthy food and beverages to decrease their use. It also falls in that policy change. And SSB taxes are an area we're constantly hearing about. More and more cities are looking at passing this kind of legislation. And to date, I'm not sure that the taxes are really big enough to see a large change in consumption patterns. However, that evidence base is still growing. And what we are seeing that they are proving to be a really important revenue source that could be reinvested in other healthy programs to support the health of communities, from healthy food financing initiatives to other programs supporting nutrition and childcare, et cetera. One quick piece I want to highlight that really thinks, going back to and expanding across the entire socio-ecological model and what healthy eating research is doing, we are really now thinking more about access to healthy food as a social determinant of health. And social determinants of health are defined as the conditions in which people are born, grow, live, work, and age, and really have a big impact on health inequities and the unfair and avoidable differences in health status seen within and among communities. Because we've really been trying to think more intentionally about how we are really looking at all the layers, in 2018, we created a new model that we really thinks promotes healthy eating among children and their families, especially among lower income and racial and ethnic minority population groups that are at highest risk for poor health and well-being. So thinking about, Black, Hispanic, Native American, Alaskan Natives, Asian Pacific Islanders, and rural communities. These are the same groups that we have seen suffer more from COVID-19 and related complications, and that have significantly higher rates of diabetes and obesity than their white counterparts. Ensuring that populations affected disproportionately by obesity and poor health benefit from preventative strategies, as we've been talking about, is among the most challenging of issues in policy and practice. So what we've tried to do with this model is really think about how can we place a new emphasis on the interaction of social, political, economic, and familial influences and environments on nutrition, healthy eating, and healthy weight. And the idea that the starting point for this work will differ according to social context. Yet PSE strategies are not often adapted like this or implemented in this way. So we really need to think about approaches that cut across multiple levels, empowering individuals and families to make healthier choices, creating or adjusting microenvironments where children and families live, learn, work, and play, and building supportive macro environments that provide families with adequate economic supports and poverty reduction strategies. For example, applying this framework to an early intervention designed to promote diet quality and minimize obesity risk for new parents and their babies might look like this. At the empowering families level, really educating parents on strategies around what and how to feed their infant in the first year. Implementing up-to-date nutrition standards and feeding practices in the infant's childcare setting would be around enabling a microenvironment. Then improving access to economic supports for the family, such as the Supplemental Nutrition Program for Women, Infants, and Children, or WIC, or the Supplemental Nutrition Assistance Program, or SNAP, for family, so that they have more money available to spend on healthy food, fits in that, in that enabling microenvironment. And then lastly, examining a parent's access to paid family leave or breastfeeding supports in the workplace, which would improve a new parent's ability to follow through on the recommended feeding practices, is a much more upstream policy that we wouldn't often think about when just trying to impact what a family is feeding their young child, or what that family themselves is eating. Embedded within all this, poor diet and obesity are really important health equity issues. In order to achieve health equity whereby everyone has a fair and just opportunity to be as healthy as possible, we need to apply an equity lens across all levels of influence and these PSE strategies. So this includes addressing disparities among communities of color, between rural and urban geographic areas, in socioeconomic status, and among other groups of marginalized children and their caregivers. Not all families and communities operate within the same constraints or have the same resources. In cases where resources are lacking, this approach requires a more intentional examination of how interventions or PSE strategies may need to be adapted and tested given these new sets of constraints. And so in closing, I just wanted to share this example. This is from a recent expert panel we led to produce feeding guidelines and recommendations for birth to 24 months in preparation for the 2020 to 2025 DGAs taking on this topic. It really illustrates the numerous system-level changes needed for prevention of childhood obesity during the first 2 years of life. These include addressing early care and education programs, the healthcare system, food assistance programs, and the marketing of food products to young children and their caregivers. All of these pieces have a big impact on what young families are feeding their children. These are the policy vehicles for creating lasting systems and environmental changes to make the healthy choice easier for families. But to the previous model, when implementing these changes, we need to pay attention to the underlying inequities facing our target populations. Resource issues are one of the biggest differences between people in communities affected by disparities and people elsewhere. They cannot be ignored if we want to have real impact on ensuring that all Americans have an equal opportunity for optimal health. Thank you very much.